So it's decided to start the Sepsis Six, this simple treatment pathway that any healthcare professional, provided there's a qualified prescriber around, can deliver to make a real difference to their patient. Clinical environment and the way in which the patient presents will determine when the Sepsis Six is started. For some, particularly for healthcare professionals working outside hospitals and for people working in areas like emergency departments and acute medical units, we might not have the full battery of laboratory investigations, and so we might choose to focus on either obvious septic shock or on red flag sepsis before we start treating the Sepsis Six, those parameters that we've identified from the news score that trigger a score of 3 or more. Outside hospital, we're making the assumption that those patients have severe sepsis. The idea of the Sepsis Six is we prevent deterioration. This is the cascade of deterioration. A majority of patients, when they first present to healthcare, will of course not be healthy by and large, but will have had some sort of acute insult. They'll be feeling unwell. For patients with sepsis, that acute insult will be the onset of an infection, and patients will typically present when they're beginning to develop systemic signs of organ dysfunction. So they might feel breathless, they might feel very fatigued and tired, they might have noted that they're not passing urine well, their skin colour might have changed. And with sepsis, these are the cardinal signs of ensuing organ dysfunction. We have the opportunity here to intervene and to rescue patients such that they might need a short hospital stay if at all, or they might certainly avoid intensive care in the high dependency unit. But if we don't treat early organ failure, it will progress to established organ failure. And that's the start of an inexorable decline if untreated. Patients with severe organ failure will need to go to high dependency or to intensive care in order to have that resolved. If it's unchecked, it will develop to multi-organ failure and death. So as we've discussed in a previous podcast, sepsis starts with an infection. And when that infection triggers the systemic inflammatory response, or SIRS, then that is sepsis. Patients with uncomplicated sepsis are a difficult bunch to identify. They might have subtle signs, a slight tachycardia, a slight tachypnea. They might have signs that we might not normally think to measure. Their white blood cells might be abnormal, their temperature might be abnormal. And so we typically identify patients once they've started to develop organ dysfunction. Now, we have criteria within hospital to denote severe sepsis. Those are criteria set by consensus standards, but often rely on laboratory results, and we can't easily identify them outside the hospital setting. And that's why we've developed the concept of red flag sepsis. As I've just said, red flag sepsis outside the hospital setting can be assumed to be the same as severe sepsis and should mandate immediate intervention. If the organ that's failing is the circulation, and that would be manifest either by a low blood pressure, particularly after we've delivered fluid challenges, or by a high lactate, then that's septic shock. The mortality from septic shock is around 50%, the mortality from severe sepsis is around 35%. These are some of the sickest patients we'll encounter. So here are the Sepsis Six. There are, unsurprisingly, 6 of them. High flow oxygen, blood cultures, IV antibiotics, fluid resuscitation, measuring the lactate, and measuring the urine output. And I'll explain why each of these are important, but we'd like each of these to be done within 1 hour. We don't have to wait for 59 minutes to do number 6 as quickly as possible, and many organisations have individuals who've completed the Sepsis Six within a matter of minutes. The quicker the better, time is of the essence. And if patients don't respond, then we need to get intensive care support down to the emergency department, to the acute medical unit, or we need to get the patient into hospital as quickly as possible so that intensive care can get involved. Step 1, oxygen. Now, in sepsis, there's a critical imbalance between oxygen supply and demand. Now, what does that mean? It means the tissues are crying out for oxygen, which they can't get. There are lots of reasons for this. First, the blood pressure might be low. In sepsis, the blood vessels dilate, vasodilatation. That causes a bigger space for the blood to fill. So if the blood volume stays the same and it has a bigger space to fill, the blood volume seems relatively smaller. We call this relative hypovolemia, and that on its own will cause a drop in blood pressure. Second, we get leaky capillaries in sepsis. So fluid, primarily water and solutes, leaks out of the circulation into the tissues. So we had a bigger space with the same blood volume. We've now got a bigger space with a smaller blood volume because a lot of the water has left the blood, and that's an absolute hypovolemia. And those two things conspire to cause a low blood pressure. That will reduce oxygen delivery to tissues, and the leaky capillaries will cause edema, which increases the distance oxygen has to diffuse from the blood vessels to the cells of the organs, and that compounds things further. And then there's a fourth factor, which is tiny, tiny blood clots, microthrombi, that can lodge in the capillaries and cause impaired delivery of oxygen. So tissues are crying out for oxygen, and that's exactly why in sepsis patients are exempt from the British Thoracic Society guidelines for oxygen. Our aim is to flood the lungs with oxygen, to flood the alveoli with oxygen. So high inspired concentration in the early stages raises the partial pressure, the sort of proportional amount of oxygen in the alveoli, those tiny air-filled sacs, and that means that the blood cells in the capillaries, the red blood cells, can absorb more oxygen. So what might that mean? Well, each molecule of hemoglobin in a blood cell can carry 4 molecules of oxygen. The more oxygen it has, the more readily it gives the oxygen up to the tissues. So let's say we had a patient with 92% saturations. They might have 3 molecules of oxygen on most of their hemoglobin molecules, and perhaps some with only 2 molecules. And they're going to have a reduced ability to deliver oxygen to these oxygen-starved tissues. If we can up that to 4 molecules by getting the SATs up to 98 or 99%, then that can make a big difference to the patient and a big difference to whether they develop organ dysfunction or not. You will know not to give high-flow oxygen lightly in patients with COPD. And patients with known moderate or severe chronic lung disease, we do need to be very careful. Hypoxia will still kill these patients before high carbon dioxide or hypercapnia. So we do still need to make sure they have adequate oxygen, but you're going to have a lower threshold for taking repeated blood gases and a lower threshold for calling a senior to see the patient. Lots of oxygen in the blood means the organs are happy. I'm not entirely sure why the eye's there, but certainly the brain. Patients with sepsis can present confused or agitated. They can be slurring their speech. They might even be unconscious. And just by fixing oxygenation, by a combination of oxygen therapy and fluid resuscitation, can allow the patient to wake up and improve. The liver can take a hit in sepsis. We get an ischemic hepatitis, and that can be improved just by getting oxygen delivery better. And the kidneys similarly. The second step is taking cultures, and we talk about blood cultures, and blood cultures are important. We should try to take blood cultures before we deliver antibiotics. That's important because if we can take blood cultures before the antibiotics are given, then we've got a greater chance of capturing the bugs. We need to take at least 1 set, but it's a good practice if the patient has a vascular access device like a Venflon or a central venous catheter in, and it's been in for a day or 2, then we should take a set from that device as well as a fresh stab percutaneously. When I wouldn't want you to wait for blood cultures before giving antibiotics is, firstly, if it's going to take a long time to get the bottles. The antibiotics will save the life, the blood cultures will make a difference in a couple of days' time. The main time I wouldn't want you to delay is in purpura fulminans. That's the name for that characteristic rash you see in meningococcal disease or streptococcal disease. If you see that rash, give the antibiotics, don't think about the blood cultures. When you're taking cultures, think about other samples. Do we need to send some urine, some cerebrospinal fluid, some wound swabs, some sputum? And also, when we're thinking about identifying the source of infection or the bug that's causing the infection, think about, do we need to do some imaging? Do we need to consult a surgeon? Might there be, for example, an abscess in the abdomen that needs draining? Might there be a device that we need to remove, like a Venflon or a central venous catheter? If we do identify a source of infection that we can drain, then we need to do that within 12 hours at the most. So it's worth thinking about when we do cultures. When we take cultures, do them properly, please. We need to do them aseptically. We need to sterilise the skin with 70% alcohol and 2% chlorhexidine. Modern practice would use butterfly devices. We'd flip the tops off the blood culture bottles and then we'd clean the rubber swabs before we inject the blood. Volume of blood's important in blood cultures. If we can manage 10 mils in each bottle, that's great. The capture rate increases the more blood we put in. But if we can't fill the bottles, preferentially fill the aerobic bottle. Let's put a good 6 or 7 mils of blood at least in the aerobic bottle before we put what's left in the anaerobic bottle, because most bugs will grow in the aerobic bottle. Antibiotics, the single most important thing we can do. We need to start therapy as soon as possible and definitely within the first hour, and of course preferably after taking blood cultures. Now think about what happens. This is mainly aimed at those prescribing antibiotics in hospital who will frequently expect that the nurses give the antibiotics. If you're a prescriber, think. Have you delegated it to an administrator that you trust? Does the nurse that you've asked to give the antibiotic know how urgent they are? Could you give those antibiotics yourself? Could you take responsibility to draw them up and administer them? You probably should as a prescriber, because we see delays in various hospitals around the UK of 3 or 4 hours, even for patients with sepsis, between prescription and administration. Think about it. This graph shows that the longer we delay giving an antibiotic, the less likely the patient is to survive. And the sort of tagline that it gives us is phenomenal. For each hour we delay in administering antibiotics in septic shock, the risk of death, mortality, increases by 7.6%. So I mentioned that we see delays of 3 or 4 hours commonly. Think about it. As a prescriber, you prescribe an antibiotic, you know it's urgent, you know it might be life-saving. If you give it yourself, you might avoid increasing your patient's risk of death by perhaps 20%, perhaps 30%, perhaps more. The College of Emergency Medicine have looked at this. We set some standards with them back in 2008, and in 2009 the college did an audit. The standard was that 50% of patients with severe sepsis or septic shock should get their antibiotics within an hour. We failed. Only 27% got their antibiotics within an hour. And I've seen the results from the repeat audit this year. By the time you listen to this podcast, they're probably out, and you'll know that we're not much better. Fluids. Fluids are all about improving oxygen delivery. We've got to restore the circulation. Restoring the circulation, restoring oxygen delivery will reduce organ dysfunction, reduce multi-organ failure. And it gets more blood, gets more oxygen, improves perfusion of the tissues. So we give fluids judiciously, but fluids are important, even if the patient's blood pressure hasn't yet fallen. Cardiac output is determined by two things. The amount of blood the heart puts out per minute is determined by the number of times it beats, the heart rate, and the amount of blood it ejects with each beat, the stroke volume. So together they form the cardiac output, and that's how blood gets around the body, that's how our tissues get perfused. Think about this image here. We've got on the left a tall person who's painted red and a shorter person who's painted green, perhaps a child. Now, underneath there, we've put stride length. The taller person has long legs, and so they take great strides. And so they're going to get where they're going quicker. The shorter person has short legs, they're going to take longer. So if you think about what happens when you walk with a child, to keep up with you, the child increases their number of steps per minute, increases their heart rate, if you like. So they're increasing the number of steps. So to get to the same place as you would get to in perhaps 60 steps, the child will have taken 120 steps. They'll be working harder. That's analogous to cardiac output. The stroke volume is determined by the venous return to the heart, which in turn is determined by how full the circulation is. So if we improve venous return with fluid challenges, we're going to improve the stride length of the shorter person there, perhaps to that of the taller person there. What that will do is improve the cardiac output. Now the heart will have been behaving a bit like the shorter person on the right. It will have increased its heart rate to try to cope with the fact that it's now got short legs. It's now got a low stroke volume. As we improve the circulatory status with fluid resuscitation, we start to see the heart rate coming back down to normal because it no longer has to work as hard. So we give fluid challenges in divided boluses, 500 mils at a time. We tend to use crystalloids these days. So that would be something like Hartmann's or Plasmolite, a more modern equivalent, or normal saline, which is safe provided we don't give too much of it. Try and avoid dextrose-containing solutions for resuscitation. And it says that we're going to give up to 30 millilitres, per kilogram in divided bolus dose. Now, I'm about 70 kilos, so for me that's just over 2 litres of fluid. So you'd put up, if I was in shock, you'd put up 500 mils, you'd run it in quickly as fast as possible, and then you'd reassess. And you'd say, well, what's happened to Ron? Has his heart rate come down? Let's say it was 110 to start with, it might have come down to 90. Has his blood pressure gone up? And then there are other things we can look at that are very useful. Capillary refill, when done properly, is useful. Urine output's useful, and I'll explain why shortly. My respiratory rate might have fallen as you resuscitated me. My lactate might have fallen, and we'll talk about that in a moment. And if I was subconscious or agitated or confused, I might have woken up a bit. Just like being careful in patients with pulmonary disease, with oxygen, in patients with cardiac disease, we need to be slightly cautious with fluids. A sick heart still needs to be relatively full. An empty heart is never happy. But we're going to use smaller volumes, we're going to have more frequent assessment, and just like with the oxygen issue in COPD, we're going to have a lower threshold for invasive monitoring and a lower threshold for getting a senior down. Here's Miss Pac-Man for those of you that have read the manual. It was our illustrator's idea, and we can see in the top example that the circulation's full, the reservoir is at high, and the heart's healthy. Miss Pac-Man is getting a good soaking there because we have a high circulating volume, we have a good cardiac output, and we have a good arterial tone. So she's well perfused. In the second example, we see a common occurrence in early sepsis. Vasodilatation and relative hypovolemia works together with leaky capillaries and absolute hypovolemia to drop the circulating volume. This means that even a healthy heart becomes exhausted very quickly. It increases the heart rate, but it can't compensate. And so the tissues are crying out for oxygen, they're crying out for perfusion. In the bottom example, we've partially fluid resuscitated, the circulating volume has been improved, but we've left it too late. The heart's become exhausted, the patient's probably got a metabolic acidosis, and any amount of fluid therapy will not rescue that patient. That patient will then need to go to ITU. So the idea with fluids is to catch the patient when their reservoir is a bit empty, but before their metabolism and before their heart starts to tire. And that's why fluid therapy in sepsis is urgent. Lactate's important because it identifies sick patients. We measure the lactate. If it's high, above 4 particularly, then that denotes septic shock on its own. More importantly, we know that lactate, the higher the lactate, the more likely is the patient to survive. But I use lactate a bit like capillary refill. As we start to resuscitate the patient, if we're doing well and if we're successful, we'll start to see the lactate fall, and that can be very reassuring. If the lactate doesn't fall with fluid resuscitation, it suggests that the patient's going to need invasive monitoring. Urine output's the last goal of the Sepsis Six. It's important because it's a great window on the circulation. Our goal is to achieve a urine output of 0.5 ml per kilogram body weight per hour. So for me, that's 36 mils per hour. But for an average patient these days, that's around 40 mils per hour, and for some, many more. We can only achieve this with accurate urine output monitoring. Of course, if you're in primary care, the back of an ambulance, the emergency department, you're not going to be able to achieve a 24-hour fluid balance chart with urine output, but we at least need to make sure that the next person in the chain knows it's critical to measure the urine output. Just start a chart. Just make it clear that this needs measuring. For many patients, this will mean catheterization. And urine output's important because we measure blood pressure, but blood pressure is only a part of the issue. If we think about it, we can have a patient with a blood pressure of 150/90, but if their heart is shattered and their cardiac output is only 1 litre per minute, their tissues are going to be in real trouble. Similarly, if we've got a patient with a blood pressure of 90/50 but a cardiac output of 10 litres per minute, then their tissues won't be quite so crying out for oxygen. So this graph shows why urine output is important. It's important because over a range of blood pressures, blood flow to the kidneys is preserved. So urine output doesn't help us determine what the blood pressure is. We can already measure the blood pressure. But if we drew a straight line from the bottom left of this graph to the top right of this graph, that would roughly represent how urine output responds to cardiac output. As the cardiac output falls, the blood flow to the kidneys will fall and the urine output will fall. So we measure blood pressure, we can't measure cardiac output. Urine output is a great window on cardiac output and allows us to tell when the patient's beginning to decompensate, the patient's beginning to get in trouble. So here's the Sepsis Six in words again. Step 1, give high flow oxygen. Step 2, take blood cultures. Step 3, give IV antibiotics. Step 4, start fluid resuscitation. Step 5, measure the lactate. And step 6, measure the urine output. Do so within 1 hour, working together with colleagues upstream and downstream from your clinical area, and you'll go a long way towards saving your patient's life.